everyone, it's Rachel here. I'm so excited to see you all. So for today's video, I just wanted to do a Q&A with, the people that have been following Mommy Did You Know? We've been having a lot of pregnant people lately. So I figured it would be a great time to do Q&A, get to know each other, but also to answer a lot of important questions about childbirth and delivery, and also baby care. Throughout this whole week, I've actually been asking people questions that they would like to be answered, whether they be about childbirth or about newborn care. And I've had a lot of amazing questions throughout this week. So I'm very, very excited to go over all of them. I have some questions about GBS and childbirth, which is very important to know. I have some questions even about swaddling. So I don't really have a baby anymore. My babies are both grown, but I do have a little teddy bear that's actually Mateo's, my older one. So we can go over how to swaddle. I can go over, someone even asked me the steps to latching and how to, what does flex the hips to open the lips mean, something as simple as that. So we could go over all of those great things. So to start off, I would just like to do a little icebreaker for those who are watching now. I see we have a few people, and this is a live class. So the way that this works is it's better to be interactive, because I do have questions that are kind of pre-planned, but I want to know what you guys need individually. And the best way that we can do that is by being interactive. So there is a live chat box. So what we can do is I want to do a little icebreaker. So we can say who you are. You can say your name if you want, or you can say, my name is Mary from New York. I don't know who you are, where you're from, and let's say your favorite type of food. So at least it's, who you are, where you're from, and then just something that hopefully can connect us. So my name is Rachel, and I am from Florida. I'm just writing now so you guys can see where the chat box is. And my favorite food, I would say, is cross between Japanese and Italian. So the live chat box is now open. And you can just say where you are, where you're from, your name, and then something that we can get to know you by. And then I just wanted to start off with some of the questions. So one of the questions that I had, Paige from Colorado, and your favorite is pizza. Oh, that's my kids too. We just had pizza last night. But Mateo's favorite is pizza. He's all for it all the time. And I'm very excited to meet everybody. And throughout the class, some people can chime in that were not on before. So I'm very excited about this. So to start off, the first part, I'm going to answer some childbirth questions. And then the second half, we can answer some parenting and breastfeeding questions. So for childbirth, one question that I had that was very important was, what is GBS? And is it something that is preventable? So GBS stands for group beta strep. Group beta strep, it's a naturally occurring bacteria that a lot of women have in the vaginal area. However, for adults, there's really no harm in it. But if a baby has group beta strep as they're coming out during delivery, it can cause an infection. The baby can get sick from that. And I've actually had babies that had to be admitted to the NICU because of a possible infection. So what do they do if you are GBS positive? They normally will swab you around 36 weeks. And it is a swab that takes a few days to get those results. And if you are positive, then you would want to make sure that you come to the hospital as soon as possible once your labor is starting to get antibiotics. The antibiotics are to protect you. The antibiotics are to protect the baby. You want to have at least 2 doses. Usually ampicillin is the antibiotic of choice. They'll normally give you about 2 antibiotics. Now, if you are GBS positive, it's also very important to note when your water breaks, because that water is pretty much like a protective barrier around the baby. And then as soon as that water breaks, that's it. The baby is unprotected from everything going in and out of that area. So if you are GBS positive and your water breaks, you want to make sure to go to the hospital as soon as you can so you can get those antibiotics and hopefully get that childbirth underway. Do I have any other questions about GBS? Basically, this is something that, it's in the natural flora of our bodies. A lot of women don't realize that we have a natural flora of bacteria, both good and bad, and they all work together. So it's not necessarily that something you can prevent, but it is something that you can prevent further complications. Here I am all tongue-tied to the baby, simply by recognizing when your water breaks and recognizing when to go to the hospital and hopefully getting. How long does it take to know if the baby was impacted or did get GBS? So that is an amazing question, Lisa. So what I do as a nurse, for those of you who don't know, I work postpartum most of the time, although sometimes I do work NICU, labor and delivery. I work antepartum, sometimes a little of everything. So me as a postpartum nurse, if you were GBS positive and you did not have the treatment that you needed, we usually do an infection screening on the baby. So let's say you came in, delivered really fast, your GBS was positive, you did not get the opportunity to get any ampicillin. At that point, usually, if you did not get the treatment, we will be doing an infection screening on the baby, which basically, you remember in microbiology class how you would take a sample of something, look at it under a microscope and see if there is any growth. We would be doing that at birth with a sample of blood that is taken by a venous stick. So simple, usually they'll take it through like a butterfly needle or an IV needle, and then they will take a sample of that blood. They'll usually need about a half a cc to a whole cc, usually one cc. So it's not too much blood for it. And then they will see 24 hours after if there was any growth of bacteria. Usually, honestly, the most of the time, if I see that it comes back positive, it's usually because of a contamination during the test. So let's say like there was something on the glove, but we can normally tell that by a specific it's kind of like a type and screen that they will do for that. And how common is it? It's actually pretty common. Like me, I would say maybe like 1/4 of my patients would actually be GBS positive. Normally, you would get that test around 36 weeks. However, if you deliver earlier and your GBS status is unknown, the hospital will treat you as if you are positive, because when you're dealing with babies, they always tend to be a little bit on the safe side. So if, let's say, you did not get the treatment and then we had to do that infection workup, and then 24 hours later, that screening was positive, the baby would be admitted to the NICU until they see if what exactly is the type of bacteria. That normally takes about another day or two. And then they can see if that bacteria was actually the GBS or it was E. coli or whatever it might be. And then if it actually was an infection, the baby normally is there for about 10 days of antibiotics. If that just shows up that it was a fluke, whatever happened, maybe it was a contamination during the exam, then your baby will probably be discharged with a follow-up blood culture that is negative. If the first one's negative, you might have to wait for the 48-hour to be negative as well to go home. Usually after childbirth, you're there in the hospital for about 2 days after vaginal delivery, and then about 3 days if it is a cesarean delivery. It also depends. Like there's some doctors that would just let you go earlier, and it depends on how the baby's doing and how the jaundice level is and everything like that. So that was for GBS. And I'm very excited that you guys had these questions because it's such an important topic is GBS. Now, the next topic that someone pulled up was shoulder dystocia. And somebody wanted to know, what is shoulder dystocia? Is it something that we can prevent? And then what happens if you have a baby that has shoulder dystocia? What can happen if you have a vaginal delivery the next time? So this is actually a very important topic that everyone should know. So does anybody know what shoulder dystocia is? You guys can type up there. I'm going to do a little pop quiz. So, I mean, obviously would have something to do with the shoulder, but can anybody tell me what is shoulder dystocia? I'll give you a minute to think of that. You probably heard it, but you probably heard about it before, but shoulder dystocia is basically when the baby is coming out, exactly, Lisa, and the baby gets stuck. Definitely something you do not want to have to deal with as a parent delivering your child. Basically, the baby's coming out and then the head might come out, but then the shoulders get stuck. Now, this is something that is one of the most frightening cases for not only the parents, but also the medical team, because the fact is you don't know what's going to happen in those first few seconds. It's so crucial. Now, it's not necessarily something that you can prevent as much as something that you can see if you'll be at a higher likelihood of having a shoulder dystocia. So one of the biggest things, obviously, is having a bigger baby. If you have a bigger baby, chances are, especially if you have a smaller pelvis, the chances of having a shoulder dystocia are much greater than if you had a smaller baby, obviously. Another one is if you had a previous shoulder dystocia. So if you had one baby that had a shoulder dystocia, it can be likely that your next one will have one as well, but it's not as common as you think. It's just something that we think about. Now, if you have a shoulder dystocia, seconds are crucial. Usually a little position change and the baby comes out. They might have to apply a lot of pressure to the pelvis, which honestly is very painful. Usually the shoulder dystocias, the majority of the time, it's maybe about 20, 30 seconds, but or even less sometimes, but it's frightening, of course, as a mom. And the scary thing is pretty much everyone jumps on you. So that's one thing with the shoulder dystocia is pretty much everybody is trying to get that baby out as soon as possible. Just because every second that the baby's stuck is another second that the baby does not have oxygen flowing through its system. And then you have a much higher likelihood of having complications after delivery, with the baby. And of course, shoulder dystocias, if for too long, it can be fatal. And that's frightening for anybody, like any parent, any medical professional, because this would be a baby that was perfectly healthy. So that is definitely one thing to think about. So if you have a baby that has shoulder dystocia and you are having a baby again, somebody asked me, is it safe to have a vaginal delivery after you had a baby that was stuck the first time coming out? That all depends on you, and the baby. What happened during the shoulder dystocia? Was it just like a 10-second shoulder dystocia that they were able to just position change and get the baby out? Or was that a very severe shoulder dystocia that the baby actually had permanent brain damage or something from that? So there's a wide range of possibilities there. But I would say with me personally, I make decisions that give me peace. If I have peace with a decision, it's normally something that I feel good about. If it's something that irks me in my gut, and as parents, in the end, you guys have the final say. Us as medical professionals, we can tell you something that we think and we can educate you, but in the end, it is your decision and you have to trust your gut. The majority of the time, some precautions that we'll take is one, we'll make sure that the baby's a decent size compared to your pelvis. So for example, if let's say you had a shoulder dystocia and you're going to have a 10-pound baby and you're a small little lady, we might have to have a few discussions there, see if maybe a cesarean might be the better route. If it was a minor shoulder dystocia the first time around and the baby's a good size and both you and the doctor feel confident, you might be able to try vaginal delivery again with maybe an episiotomy. Sometimes is something that parents would prefer to do. That is when, and that actually goes into my next question, is when they would have a surgical incision to open the area a little bit wider so the baby will be able to come out a little bit more freely. Of course, some people, they prefer to tear naturally, but that would be something that they might do or discuss with you as well if you are interested in that. Sometimes also they might even deliver you in the ER, not the ER, the OR, or even around the OR. They might even deliver you in a room next to it and even have maybe some anesthesiologists next to you. I've also seen them actually have the NICU team. That is one reason why that's one thing you can also talk about with your doctor and your hospital. Research your hospital. What type of NICU team do they have? Is it just is it a level 1, 2, or 3? 1 is something that, they might handle some babies that are a little premature, but they're not too bad. But if they are bad, they would have to get shipped out to another hospital. 2s and 3s, those the level 3s are the ones that handle the really really sick babies. So you would think the hospital that you're delivering at, what type of NICU does it have? And does it have a neonatologist on staff at all times? Because not all hospitals do. So I would be looking into that. So just women have improved healing after a natural tear versus episiotomy. So that was Joni and Keith's question, was episiotomies versus natural tears. So besides pretty much we talked about the shoulder dystocia enough, but if you guys have any other questions about it, you can put it in there too. But episiotomies versus tearing naturally. There are pros and cons for each one, but in the end, it is your body and it's something that you will choose about. So natural tears do tend to heal faster. That's what the research, episiotomies actually tend to heal a little bit quicker than natural tearing. Natural tearing shows that it takes a little bit longer. However, natural tearing tends to have a little bit more natural healing than episiotomy. And also natural tearing tends to hurt less than an episiotomy. Episiotomies actually do hurt a lot more than natural tearing. So that is one thing that you would also want to think about as well. With episiotomies and natural tearing, you can try to use ice packs for the first 12 to 24 hours if possible, especially if it has a lot of swelling. You can try Tux pads, Tux pads are basically witch hazel pads that help to reduce pain down there. It also helps very good for hemorrhoids. Me personally, I did natural. I preferred not to have an episiotomy unless it was medically necessary for me or the baby. Episiotomies with a surgical tear, what happens is that it is a little bit easier to heal because it's not so jagged. However, your body naturally is able to heal itself, if you think about that, because women have been delivering naturally from the dawn of time. But of course, it all depends on you personally. Some people also might think about that episiotomy. Sometimes if the baby comes out, you might not have tear at all. That's actually something that some people don't realize, is that you will not necessarily tear every time you have a baby. I don't know why people automatically think when the baby comes out, they're automatically going to tear every time. Just because you have a baby does not mean that you tore. You can actually be intact or even have superficial lacerations, which can be, easily stitched. There's 1st degree, 2nd degree, 3rd degree, and 4th degree, which you pray that you don't have. But 4th degree is all the way down there. And actually that is one of the reasons I've actually had people do cesarean births because they tore so bad down there. So some people will choose to have an episiotomy so that they don't have that giant tear. But, that all depends on the person. Some people also do perineal massage. Most doctors do perineal massage now, where they will take a castor's oil or a natural oil, and they will massage the perineal area as the baby comes out. I've seen those and that works really well. I've also seen doctors actually talk about the timing of pushing and how important that is. Because one big reason that you're tearing is because there's so much pressure. If you're thinking about it, there's so much pressure down there. So if you are pushing when you're not supposed to be pushing, then that's when you're going to have a lot more tearing than you would if you waited for a contraction, for example, or if, let's say, the baby's too high and you're pushing really hard to get that baby out. You're obviously going to have a lot more tearing and complications after that. Do I have any more questions about, we talked about shoulder dystocia, we talked about episiotomies, we talked about tearing. Doesn't matter if you use oil versus no oil for perineal massage. And what are your thoughts on starting this at home to stretch the area? I've seen some people do it. However, there's not that much research out there right now that says that massaging the perineal area before delivery will actually make a great impact. At least from what I've seen, you can also look at A1. A1 is a wonderful, wonderful source of information regarding maternity. It's here, let me spell it for you guys on the chat over here. But A1, they are the leading source of information for maternity, and they always have the most recent research. That is something that's recognized nationally as that women's health information. So it's fantastic, and they will have the most current research out there. The most recent that I've seen is that it does not really show that much difference when it started in the home before you go into labor, before you're delivering. However, it's not exactly going to hurt either. So it's something that if you want to do because of the chance that it might help you, go for it, do it. However, it doesn't really say that there's much of a difference, but I mean, it's not going to hurt if you do it. And then as for oil versus no oil, most of the doctors that I've seen use oil, but that does not necessarily mean that someone who does not use oil is not doing it right. You know, it's just that most doctors that I've seen prefer using the oil. Do I have any other questions about anything like that? I know that's one of people's biggest fears after they deliver is down there. But after you deliver, make sure that you are taking care of yourself. You don't want to have UTIs after, because UTIs can be very common after childbirth. So make sure that you're cleaning down there with like a perineal bottle. They usually give you a clear plastic bottle, and if they didn't, you can always ask for one, or use a cup with water, whatever you can to just make sure that you are washing yourself down there, keeping yourself clean, have good vaginal hygiene after delivery, especially because if that blood sits there for too long, it can cause infection. And I mean, either way, especially if you tore. Is the massage applied while pushing, or will this happen before you start pushing? Usually it's during the pushing phase. The pushing phase can last, sometimes it lasts like a push, and sometimes it can last like an hour or even longer. With my first baby, oh man, I pushed for a good 30, 45 minutes, which is actually a good amount for your first baby. But, it was a process and it was long. And, during that time, there's plenty of time to help perineal massage. With my second baby, I didn't even realize the baby was out, honestly, because I guess I personally had a epidural. And man, I didn't really feel much at all. I just felt like the pressure, I'm like, doctor said, all right, let's do some practice pushes. I'm like, all right, great. Let's do some practice pushes. So I do the push. Mentally, I'm getting ready to push again. And then he goes, oh, your baby's here. I'm like, oh, that was it. So like every delivery is different. And then of course, like I said, the massage applied while pushing completely depends on how long you're pushing. Because if you were like me and the baby just flew right out, there's not much time. But I still both babies, I had a 1st degree laceration. So your pushing time does not necessarily correlate to the degree of laceration is what I'm saying. Because for one baby, I delivered after, 30, 45 minutes of pushing. And then another baby, I had still a 1st degree after just one push, so it really depends on the person. That's what happens. Then another question that I had besides all of that was also, what does a fetal monitor do? So you've all probably seen people attached to the monitor and the beeping. Hakas are great, and we're going to talk a little bit more about Hakas when we go into the baby section as well. For those who don't know, Haka is kind of like a manual milk collector for breast milk. And that's a new thing coming out now, especially to help with engorgement. So Melissa, I want you to ask me again if I forget about it during that baby section, because we're going to start talking a little bit about breastfeeding and things. I just want to talk a little bit. Yeah, of course, Melissa, but thank you. Please bring it up again. I just want to keep this train of thought before we go into babies, but that is such a great question, and Hakas are so helpful. So for fetal monitoring, I actually also have my fetal monitoring certification. Fetal monitoring is looking for the baby's heart rate, your heart rate, as kind of a way to see if the baby is oxygenated during childbirth. What you'll find is during childbirth that the contractions temporarily are kind of hindering the oxygen circulation to the placenta for a small amount of time. So then what happens is if the baby is not well oxygenated during your contraction, then the baby's heart rate will go down, which is an indicator that the baby's oxygen is going down. That is why it's very important to be breathing during childbirth to hopefully prevent the baby's heart rate from going down. So if they'll see that and then all of a sudden you'll hear beep, 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 you know, and the heart rate is down for a while, that's called a deceleration. So if the doctors and nurses are coming in and saying, oh, she's having decels or she's having late decels, those are all signs of placental insufficiency, basically that the placenta is not supplying oxygen for whatever reason to the baby. And the baby's heart rate is going down. And because of that, we have to intervene immediately. So when that happens, the first thing we'll do as nurses is, well, one of the first things is we'll turn you to the side. You know, usually left side is best for oxygenation, but even right side, the research doesn't really show a big difference between them, but most people will tend to go to the left side first. We'll switch you to the right side as need be, also to kind of switch the position. We'll also try to turn down the Pitocin if it needs as well, because obviously if the baby's heart rate is going down with contractions, we would want to decrease the amount of contractions that are happening. So they'll usually decrease the Pitocin, they'll turn you to the side, and all of this is happening super fast, because especially if your baby's having decels, you're probably not just having the nurse in there. You're probably having more people in there as well. And we're having other nurses also looking at the strip, you know, looking together. Is this what I think it is? You know, what is going on here? We'll also might even have you on oxygen. The oxygen is not necessarily only for you, but it's also for the baby. Because I even heard before, if the baby's heart rate is going down, why am I getting oxygen if the baby's heart rate is going down and mine's fine? It's mostly because we are buffering that oxygen supply so that when that contraction happens, that baby has oxygen to hopefully move through that labor. I actually had oxygen with my second baby. And man, I had the worst timing to take a fetal monitoring class, because right before I delivered Nathan, who's my second baby, I was up for recertification for fetal monitoring. It literally was maybe 1 week before I had my baby, and then I had to be recertified for my fetal monitoring. So then I'm delivering my baby, I'm in labor, and I hear the decel. Like, I literally heard it and my heart stopped. But you know what I had to do? And my nurse was fantastic, but she was like, I know what you're doing. You're looking at the decel. Don't look at the decel. So once it started calming down, also, it got better. Because that's one thing we do as moms, is we're like, my goodness, something is wrong. You know, what's up with the baby's heart rate? And then us as moms, we start to freak out, and then it makes the situation worse. But then, you know, once I calmed down, I was like, all right, I need to breathe. I need to help my baby. Me freaking out is not going to help my baby at this moment. So I calmed down. I did have the oxygen actually for a good hour. And then I had the face mask. And then I had it during the pushing as well. So just because you have it does not necessarily mean your baby will have problems after delivery, because my baby was perfectly fine after he delivered. So because of fast intervention, I would have to say that, the nurse really helped my baby, and we have such an amazing team of nurses. It also helps that, I work with them. So, they're always taking good care of me. Do I have any other questions about fetal monitoring or perineal massage or childbirth before we go into the babies and parenting section? Because I know that a lot of you guys are probably getting close to delivery, and then for those of you who don't know, also, I do have personal consultations, because I know that you guys have a lot of questions. I mean, I get them all the time in my email or like my Instagram page. I'll get a lot of direct messages like, hey, what do I do about this? And I have consultations as well. If you can either email me at mommydidyouknow@gmail.com. You can also check out mommydidyouknow.com and the consults tab, and you'll be able to have consultations with me. And I do have classes as well on there. A lot of them are free. I have a prenatal, I have a free prenatal class, I have a free breastfeeding class, and then I have some premium ones too, which is great. I actually have one month long course that I'm super excited about that goes over, it's like 2 weeks dedicated to baby care and 2 weeks dedicated to pregnancy and childbirth. So it's literally a month long. So that's called the Childbirth Masterclass when you see it on my website. So it's perfect. So we're going to go over baby care next for our Q&A. And I did have a few questions here, some about parenting, some about breastfeeding. But then, of course, if you have other questions, you can always ask them now also. So we had a question about the haka from Melissa, just to kind of rewind. So the haka is a new thing. You can get it on Amazon as well. Amazon is really nice for kids, pretty much everything. Like, I'm like, oh, we have some paper towels. Let's go to Amazon. But especially now. So haka, basically, you can use it to collect your milk, and it even helps with engorgement. I'm also a lactation counselor, so I will step into breastfeeding and feeding your baby a lot. And it's great to have someone who's both a nurse and a lactation counselor, so you get kind of the best of both worlds. I do not really personally see the necessity of bringing a haka to the hospital. A few reasons. Number one is because you have colostrum in the beginning, but your mature milk supply has not yet been established. And what you want to do those first few days while you're in the hospital is establish your milk supply by having frequent and effective feedings as soon as possible. Usually within the first hour of life, if possible, it's good to start your breastfeeding, to start breastfeeding and have that first breastfeeding session with your baby. If for whatever reason, let's say you and your baby are separated, then sometimes you might be separated because the baby's in the NICU or you have to stay in labor and delivery. Within the first 6 hours, you would want to start pumping while there's that separation. And then Renata wanted to know if it's recommended to bring a doula to the hospital. Of course, that is something that's a personal recommendation if you want to, but one thing to think about right now are visiting policies. So right now in our hospital, we only allow one, at least for us, we only allow one visitor that can stay with the mom and the baby for the duration of that stay. Now, if you wanted that doula to be the visitor that stays you with, for the duration of the stay, and then that would be all right. It's just that is the person that will get that identification band, and that will be that person that ends up with you. Virtual doulas, that is actually a good question, but I am not sure about that, but I'm pretty sure that they do have them out there. You'll probably just have to look. I do have virtual consultations that I have been doing in the hospital, actually. So if you guys deliver and you would like a consultation to just see if the baby's breastfeeding okay, or how if there's laboratory exams that they're doing and you have questions about, and you would just like somebody to talk over, what's going on, or, answer any of your questions, you can also ask me as well. mommydidyouknow.com. Yeah, mommydidyouknow.com. And then go on the consultations tab, and then that is a way that you can make a virtual consultation with me. And I do have new parent packages as well that you can, get like 3 or 4 sessions with me at a discount that way, just because it's best to have someone that has a relationship with you, that it's not just one time, hey, okay, this is what's you're gonna expect and but it's good to have somebody that you can rely on, ask questions, and have a relationship that knows you for your journey. And usually I recommend consultations around in your 3rd trimester, around 32 to 36 weeks to start off, and then maybe even before you deliver if you have not delivered by 39 weeks, usually to have a consultation with me then. And then you can even have a consultation with me in the hospital, and I can answer your questions as you are delivering, after you're delivering, and then I'll usually have a follow-up as well. After you deliver, how's the transition home? Do you have any questions? And those are all things that people have been asking me about that, honestly, I love doing consults just because it's one way that I can help people one-on-one. But so for the first few days, there was a lot of stuff going on. And one of the things is your milk supply. So it's all trying to be established. So early feeding, frequent, effective feeding, make sure that your baby has a wide open latch, not just kind of a shallow just over the nipple. And I'm going to do a quick kind of demonstration with the bear that I brought in the beginning of the class. So my kids right now are 4 and 2, but I actually breastfed them both for a year. That was just my personal choice, was to breastfeed them for a year. My first actually was combo breast and formula. I was not a lactation counselor back then. I didn't really know much about exclusive breastfeeding. It just I was a nurse, but I wasn't much into lactation. Then with my second baby, I was able to exclusively breastfeed. Yes, I was so excited about that. But of course, some people choose to do breast and formula. That's up to you. Both of my babies did have jaundice. Actually, both of them were under the lights. And I was able to exclusively breastfeed my second baby, even while he was under the lights. And one big reason was because I knew about milk supply. I knew about if your baby has jaundice and is under the lights, your baby needs hydration. The best way to hydrate your baby is making sure your milk supply is established. So I fed him frequently. I also pumped. So, I got some extra volume that I can give the baby, and he was able to get that bilirubin down. Bilirubin comes out with the stools. The more baby poops, the better that bilirubin goes. So just because your baby has jaundice does not necessarily mean that you will need to formula feed, as long as your milk supply is established and that it's a good enough volume for your baby. But if you do need to formula feed, I don't want you to feel bad either, because, there are some people that will have to supplement, and it does not make you any less of a mom. That's very important that you guys know that whatever your feeding choices are or whatever ends up happening, that it does not make you any less of a mom if the original plans that you had in your head do not go according to plan. If you had in your mind that you wanted to breastfeed and something happens, the baby's on supplementation, you're still the best parent that you possibly can be, because a fed baby is the best baby. I know that a lot of people say breast is best, and it is very good. It's very helpful for your baby, but in the end, fed is best, and your baby needs you more than anything. So I'm going to give you a quick demonstration of a latch, okay? And this is important because if you want to establish a milk supply, it's not enough just to put your baby on every 1.5 hours to 2 hours and just assume that your baby's getting enough to eat. What you need to do is make sure and confirm that your baby is actually eating right, and that your baby's sucking, your baby's swallowing, and your baby is latched on correctly. So the first thing that we do, kind of easy because, I mean, my bear is naked, but you want to be skin to skin. So skin to skin is not skin to blanket, and skin to skin is not skin to shirt. So in this scenario, mom would actually have a bare chest. Baby would have skin to skin as well. I usually make sure the environment is conducive to breastfeeding as well. That is equally as important as the latch, honestly. So you would want to make sure that there's not too many distractions. There's not too much noise going around. There's not too many voices chattering. And you want to make sure to stay positive. No lie, so many times I'll come in to help a patient and their family, and they'll put the baby to the breast, and then they just go, that is the worst thing you can do when you start a breastfeeding session. Your body language and what you say makes a huge difference. When you put the baby onto the breast, don't go. All right, I got this. Makes a big difference. So your skin to skin, make sure your baby's diaper is changed, that is clean, because if your baby has a dirty diaper, it can actually affect the breastfeeding session as well. What I'll do is I'll also stimulate and massage the breast as well. So what I'll do is I'll actually come from the top, work your way down. You can even put, especially if you're engorged, like a warm washcloth, put it on the breast to kind of help stimulate. You alternate the breast that you start with. So let's say you start with this breast on this feeding, you will want to start with the other breast, the next feeding, and offer both breasts with each feeding. That is a good way to help establish your milk supply because you're stimulating both breasts, because babies tend to feed better from the beginning of the feeding than they do on the end of the feeding. So let's say it's the beginning of your feeding. All right, I'm massaging my breast. I'm expressing colostrum. The way that you express colostrum is not like mature milk, where mature milk, you just kind of, go like this and it all squirts out. With colostrum, what you want to do is, so there's the dark part is the areola, and then there's a nipple that's obviously, somewhere in the middle, sometimes different, every anatomy is different. With the colostrum, your receptors for milk production are in the back of the breast. They're not in the nipple. Okay, it's towards the back. So actually what you'll do is in a C position, you'll put one finger on both sides of the areola, all right, that dark part. So pretty much you're putting it around your areola. Then you're pushing back towards the back of the breast, and then you're pushing out. That is a key technique of hand expression. So you're pushing back, all right, and then you're pushing out. That is something that you can try to practice even before you deliver, as long as you are not trying nipple stimulation to start labor. I've seen people try to have nipple stimulation to start labor. That is like if you are ready for delivery, but definitely don't do that if you're preemie. Anyways, so I express some of the milk. I'll put it on the tip of the nipple because babies, they don't really have a lot of sight of smell in the beginning. They don't have a lot of sense of sight. They rely on smell. So as our babies rely on smell, I am doing tummy to tummy. Belly button, pretty much to belly button is what you're thinking about, okay? And then I personally like cross cradle. I know that a lot of people, let me move it down. A lot of people, they'll try to breastfeed like this. But as you can see, like the belly is up, the baby's not in a very conducive position, and newborns have very bad control over their head. So they're kind of like this, mom's kind of doing one of these numbers, or even kind of trying to chopstick, and it doesn't really work very well for newborns because newborns don't have a lot of control over their head. This is a little bit better once, you guys get more comfortable with each other. So what I do is I'll switch it. So what you're doing is you're using your hand here. So my forearm is supporting the back, and you can try this even with like a teddy bear, whatever you have. I have a teddy bear here. So I'm using my forearm to support the back. This is called the cross cradle or the clutch method. And then the baby's feet are comfortably tucked here so that he feels nice and secure. And then what I'm doing over here is that the baby's nose is to my nipple, not mouth to nipple, okay? A lot of people, they just go, take it, and they shove the baby's, mouth to the breast. What you want to do is nose, because we're working by smell, right? We're not working by sight. So with that express colostrum, I'm putting the baby's nose to the nipple. What I do is right underneath the nipple, there's this magic spot here that I kind of found out while breastfeeding my kids. But there's this magical spot right here underneath the nipple. And then I just swing the rest of my fingers underneath and the rest, my thumb on here that I can use to help the baby to breathe. And then as the baby smells and opens, that's when I put the baby up and over and latched on. So that is kind of Rachel's clutch cross cradle method for you guys. So basically what you're doing is tummy to tummy, nose to nipple. Oh, and then the flex the hips, because someone was asking that. All right, so flexing the hips, basically what you're doing is your baby, and of course this is not a very good flexing controllable baby, but as the baby's like this, the legs are a little bit flexed. You know, when you're like almost like you're flexing your arms, but you're flexing your legs. When babies flex any part of their body, mostly their legs, their natural reflex is actually to open their mouth. And a lot of people don't realize that, but that's actually a very, very simple way to get your baby to open the mouth because it's a reflex. It's something that kind of automatically happens. You know, babies have their rooting, they're moving side to side, but they're also flexing their legs to help open the mouth. So by putting the baby skin to skin, tummy to tummy, nose to nipple with the express colostrum, and then the baby with that flexed legs also, lips open, and then the baby can latch on. Make sure that the baby is not nipple feeding. It is breastfeeding, not nipple feeding. So with that in mind, make sure that the baby has wide open to the feeding, that when you're looking at the silhouette of the mouth, and daddy can help you with this too, or, you know, whoever is with you, your support person, make sure that the silhouette is like and that the lips are flanged out, and that it's not like an ooh. And what you'll see also is a lot of times, if the baby's not latched on right, one of the lips might even be going in like this. And you might even hear like a clicking. It'll go like as the baby's latched on. That can even be a sign of tongue tie. It's when the frenulum, which is the skin that's underneath the tongue, some people have that. And if the baby has a very tight frenulum that the tongue cannot freely come out of the mouth, sometimes what you'll see is that kind of clicking. So that's one thing that you would look into as well. So as the baby's latched, you're going to have that wide open, lips flanged out. You do not want to hear any clicking. If you do, sometimes it's just that the baby might have lost the latch a little bit, and you just have to readjust. Another thing that a lot of people don't realize also is that there's a way to latch off the baby without ripping your whole nipple off. And what you do is you just simply take a clean finger and then kind of press down a little bit to release the suction, and then you can take the baby off that way. It is better to latch the baby off completely if the latch is wrong, rather than continue the feeding with a incorrect latch, because it only takes a few sucks to really mess you up for a long time. And then what you can do is when you're done with the feeding, you made sure that you had sucks, that you had swallows. You can even compress as the feeding is taking place to help the baby, because there's two big milk producing and releasing hormones that are at work here, and that's oxytocin and prolactin. So prolactin is the milk producing hormone. That's the hormone that's saying, all right, we got to produce milk. That works by emptying your breast. The more the breasts are emptied, the more prolactin is released. So the more the baby's feeding, the more prolactin is saying, hey, it's time to start producing more milk. Oxytocin is that milk releasing hormone. You might have the milk all up in you, but that does not necessarily mean that the milk is coming out. The way that it comes out is with that oxytocin. Oxytocin is the same thing that's causing your uterus to contract too. So that's also why you might have some more contractions as you're breastfeeding. That's just because that same hormone that's causing that milk to come out is also that same hormone that's keeping your uterus contracted and preventing bleeds. So that is why it is so important to understand how those kind of how those play a role in the breastfeeding. Do I have any other breastfeeding questions? It's all milk supply. Milk supply is like a business. It's a supply and demand. The more demand that you have, the more supply. So try to feed as frequently, as early, and as effectively as possible in the beginning. And then try not to introduce supplementation unless it's medically necessary or if it's your choice. Like if you wanted to start out formula feeding, it's just keep in mind that as you are breastfeeding, you are stimulating the breast, but every time you give a bottle, you are giving less stimulation to the breast, therefore telling the body to create less milk than your baby is taking in. And now Melissa wants to know, how do I build up a supply for when I return to work? I'm actually pro at this. I had to go back to work 6 weeks after my after my last delivery with Nathan. And really what makes a big role is your perspective, is your mentality, is the words that you're saying to yourself and your support system. And then do you feed until the baby stops themselves? And look at the baby more than the clock. So some nurses, especially nurses, will tell you feed 15 minutes on each side. I tend to look at the baby more than the clock. And that's an actually good way to build up your milk supply. Also, Melissa, for work is feed on cue when your baby wants it as frequently as possible when you are home to establish your milk supply. And then whenever there's a missed feeding, whether it be by separation or whatever, whenever there's a missed feeding, make up for the missed feeding with a pumping session. When you are pumping, I'm actually a pro at pumping too, is make sure that you are pumping and compressing. A lot of people, they'll hold the pump like this, and they'll hold the pump and then they'll just let the pump go like that. But remember how we were talking about compression and how oxytocin is the milk releasing hormone. Oxytocin is released when the breast is compressed. So therefore, if you are pumping and you're not compressing the breast, you're not going to create as much milk, and then your milk supply will drop. So a key to that is proactive pumping. It's like power pumping. What you're going to do is pump, and you're going to compress at the same time. Make sure that you keep your schedule, Melissa, also. So if you normally feed every 2 hours, try to pump every 2 hours as well. That will help to keep your supply up when you go back to work. And then for Jessica, you said, how much water should mom drink per day to create and maintain a good milk supply? So moms are notorious for taking very good care of their babies and not very good care of themselves. So it's at least 8 to 10 glasses a day. Now, to help remember, this is something that I had to do because I had really bad dehydration from overpumping. So what you do is, let's say the baby has to feed 8 times every 24 hours, is I made a routine. I'm like, I'm going to go to the bathroom because you have to try to pee every 2 to 3 hours. And then I would have a glass of water and feed my baby. So it was a routine every 3 hours. I'm like, okay, if I have to have 8 glasses of water and I have to feed 8 times a day, let me feed and have a glass of water. And then that also helps me because breastfeeding makes you very, very, very thirsty. So Jessica, I hope that answered your question. It's all about, more than anything, it's your routine. It really helps you out. And then Deja had a question about nipple confusion, when to introduce bottles to prepare for work and avoid creating any confusion with breast nipples for when you're at home. So nipple confusion, it's something that a lot of people think about as to when your baby is learning how to breastfeed and you are introducing a nipple. So what ends up happening is your baby is learning to breastfeed and learning the shape of your breast. And then you will, let's say you introduce a pacifier or a nipple, and then they get confused because they're learning 2 different things. I would say sometimes it's not necessarily the confusion as much as the energy used for, like, let's say it's a pacifier, is let's say someone's using a pacifier, a baby's using a pacifier, they're using up all the energy on the pacifier so that when it's time to go on the breast, they don't have the energy back, especially for newborns. So that's one thing. Usually the Academy of Pediatrics recommends not to introduce nipples until breastfeeding is established. But of course, some people do have to supplement. And I know some people start supplementing, like they'll do like a spoon or a syringe, but sometimes it's not necessarily the best way to feed going down the road, because it'll be hard to supplement via syringe, like an ounce of, whether it's your express milk or formula. So sometimes you might have to introduce a nipple a little bit earlier. What helps with that is make sure not to create an aversion to nipples. So like, let's say your baby's refusing the breast, don't create an aversion by forcing the breast into the baby's mouth. Instead, wait for the baby to be a little bit more quiet and calm, and then offer the breasts as the baby is more calm, and wait for early feeding cues rather than the later feeding cues. If you are waiting for your baby to be crying, they're going to be ravenous, and your breasts do not come out as fast as a bottle. So they're going to end up being aggravated. So usually early feeding cues is, you'll see a REM movement is when the baby's eyes start moving. So that's one thing that a lot of people don't realize. So REM cycle is the earliest thing that you're going to see. So you're going to see your baby's eyes closed and the eyes are moving within the eyelids. That is REM sleep. And that's one of the earliest feeding cues. You'll also see the lip smacking, and then you'll see the hand to the mouth, and all of that good stuff. So those are all early feeding cues to hopefully avoid the aversion to the breast. And I think that's more of the correct term rather than nipple confusion, is that sometimes babies end up with a breastfeeding aversion, which is something that you definitely don't want. So introduce the nipple when the breastfeeding is established, and also when your milk supply is a little bit more established as well, so that it's a little bit more easier for the baby to transition. And paced bottle feeding is good too. If you haven't subscribed yet to my channel, definitely do, because I also have some bottle feeding tips, because I know that, some people, they have to give a bottle early on, things like that. But there's something called paced bottle feeding. Paced bottle feeding, basically, instead of holding the baby like this and putting the bottle like this, you'll actually hold the baby upright, and then you will offer the bottle actually parallel to the floor like this to help prevent too much milk going in too fast. And then that is pacing the baby so that they can have it a little bit slower. And that's a good way to have breast and formula. And then for going back to work, you don't really have to have too many trial runs. I would say a few days before you go back to work, if you want to have a trial run, and just see how the baby's doing with the bottle, see how your support person is going, and then that way they can focus on the breast. And then Melissa, do you recommend fenugreek or other supplements like mother's milk tea to help milk supply, and taking them right away after birth, or waiting to see if you need to stimulate supply? So Melissa, I think the best way to help your milk supply is by frequent and effective feedings. Sometimes mother's milk and fenugreek do help, but it's not really recommended or needed in the first few days, because you want to have a natural supply of your milk supply to be established. That is really established by the baby stimulating, and that is by also preventing the use of supplementation too early. If you did have to use supplementation, it's good to use your own milk rather than supplement first, if possible. Of course, things happen, but the supplements do help. They do. It's just a matter of if it is necessary for you. And I think sometimes they also act as a Band-Aid, because some people will use it to increase their supply, while their supply is less because the baby's not latched on, or even their supply is less because they're not feeding as much as they should be. So just make sure that if you are using those supplements, that it is not a Band-Aid for a bigger problem that you have to fix. I'm a proponent of fixing problems at the source, and not just putting something that will help to Band-Aid it. But some people do have less supply because of previous medical history. So like actual thyroid problems, for example, actually when you have thyroid issues, it actually decreases your milk supply a little bit, or you have higher risk of having smaller milk supply. Breast reduction, by the way, breast reduction actually takes away some of your milk tissue, your milk producing tissue. So sometimes that also does affect your supply. Milk can also be affected by augmentations when you add breast tissue, but more than anything, that affects storage more than your actual milk supply, just because you have less storage to hold milk, but you did not necessarily take away any milk producing tissue. So that is some things that will affect your milk supply. And this was the hour for now. I hope that you guys really enjoyed this Q&A. And then if you look on Mommy Did You Know, I have more Q&As that are signed up. I think I have like twice. Yeah, I have about twice a month. And then if you guys can do me a great favor, if you can say one thing that you learned on this class, just so that I know some things to focus on for next time, or even if it's something that I might think might be common knowledge, but really isn't, like you're like, oh, wow, I learned this and I thought it was really cool, and you can also subscribe. I have lots of great information. And then my website, mommydidyouknow.com, has a lot of great resources. It has online classes, it has consultations. Oh, shoulder dystocia. Yeah, a lot of people don't know about shoulder dystocia, but it is very, it happens every now and then, but it's good. The level of NICU in the hospital was helpful. Yeah, because it's something that a lot of people didn't know. Wow, shoulder dystocia was a very hot topic then, huh? So I'm glad that we got to talk about it. Raspberry leaf tea to prepare for labor. It was recommended to start drinking here in the last couple of weeks. Some people do. I think teas make a very big difference. So the biggest thing to help your labor is honestly calm down. Once your body relaxes, it really helps. And then lingo is a big thing. Yeah, definitely. Even like vaginal exams, dilation, effacement. Sometimes we're doing vag exams and people don't know half of the stuff we're saying. So if you do want to talk more, of course, you can always do consultations. You can do the classes, and it really helps out. I would love to teach you everything that I have and like take my brain and just like stuff it in you guys. But of course, it takes a little bit of time to learn all of this. Importance of helping supply with frequent pumping, proper latching versus Band-Aid solutions. Very good. Thank you. Well, I'm glad that you guys liked this and you guys can continue following. And then on Instagram too, I have a lot of tips. I just started like a hashtag milk minutes, which actually I'm putting at least a few times a week, like different tips to help with your milk supply and breastfeeding. So I'm glad that you all liked the class. And if there's any questions that you had, you can also ask me. And then Renata, I do remember you from a few classes. So I'm very, very excited that you got to join me again. And I hope you guys have a wonderful rest of the day. And then, yeah, so it was very, very nice. Proper latching techniques. Yeah, it really makes a difference when your baby's latched on well. Even the comfort level of just having a baby that latches on well is enough. Yeah, remember, tugging is normal, but pinching is not normal. If your baby's pinching, that probably means your baby's a little shallow over there with the latch. So have a wonderful day. I'm going to end the stream now, and you can continue to check in every now and then. I always have great resources. And have a wonderful, wonderful rest of the day, guys, okay?